Hi guys, welcome back. We shall now be talking about aspects related to liver cirrhosis and its complications. The first objective of yours as a physician is to identify cirrhosis, and second would be to determine whether it is compensated or decompensated. So what do we do for it? Well, we use a child pug score, or we can use a MELD score to identify the presence as well as the decompensation component. The components of child pug score have been studied by you in multiple other subjects also, so I'll just mention the important ones that you need to remember, the parameters basically. The components are bilirubin and international normalized ratio, and that's a standard feature of every liver disease. No, bilirubin INR is always considered. There are three A's that you have to remember. That would be albumin, and as albumin will become less, there would obviously be ascites. And when liver will be damaged, there would be ammonia intoxication that would be contributing to asterixis. In child pug score, once we grade the severity of the disease, we are able to generate three categories, which would be called as A, B, and C. If the final score of the patient is between 5 to 6 versus 7 to 9 and more than 10, then we will say patient is A, B, and C. The red flag is B, that is when the person is getting into decompensation stage, and this is the time when you have to sign up the patient for a liver transplantation program. This is a MCQ that I would like you to remember, the first one for this discussion, because components you anyway know. When would you enlist a patient for liver transplantation program when it comes to cirrhosis? The answer is value between 7 to 9, that is child pug score stage B is a criteria for enlisting for liver transplantation. In contrast, nowadays, along with child pug score, what we are also using is called as MELD score, that is model for end stage liver disease. The parameters in this particular case would be the same. Bilirubin and INR are the standard features of every liver disease. The third criteria, however, is serum creatinine, and higher is the model for end stage liver disease, the mortality rate will increase. In the exam, they have asked what is the mortality with respect to score 20 to 29. So I just want you to remember it's close to 20% only. This was a very peculiar question, but you see why probably they asked was because you can see that the moment it goes up to 30, you are having almost 2.5 times jump, 20 versus 50%. So because of the steep rise in mortality, liver transplantation, if you want to plan, then it has to be before the value of 20. Now, different books are giving different answers. Some are saying 14, some say 15, some say 17. But without going into controversy, what I want you to remember is that model for end-stage liver disease helps you to determine the possibility of not only do you know that there is cirrhosis, not only do you know that it is decompensated, you can predict the mortality rates for the patient as well. That's the advantage of this over child pug score, which does not tell you about the possible mortality rates. Just write down the full form here, model for end stage liver disease, and the third parameter which has been asked for this is serum creatinine. So first priority is to identify cirrhosis with the help of the scales that I have just here explained to you. We can also do a liver biopsy to know that there is a cirrhosis. So why did I not talk about it initially? Because the liver biopsy is an invasive test, and biopsy will just tell you that, okay, when you send it to the pathologist, he will use the scoring patterns and tell you, yes, there is a fibrosis, but again, it's not going to tell you the percentage mortality. It is not going to tell you whether it is compensated or decompensated. And clinically, what do I mean by decompensated? Then clinically, if a person is having ascites, coagulopathy, encephalopathy, varices, that's decompensated. Varices can be present even in the compensated stage, but they may not have ruptured. So variceal bleeding and varices are two separate aspects. If a person is having varices and they're not ruptured, I would still say he's okay, he's preserved, he's compensated. But if they're ruptured and he's bled, and then if that triggered a hepatic encephalopathy, why? Because blood is a very good culture media. When the person is bleeding internally, because liver is responsible for synthesis of clotting factors are less. So the person can bleed internally, and blood is a very good culture media for bacteria. So if the count of bacteria in the intestine will increase, it will cause hepatic encephalopathy, it will cause ammonia intoxication developing in the individual. So we need to keep a watch on the parameters of this person. We need to check for if he's bleeding inside, we can give fresh frozen plasma so that we can prevent the hepatic encephalopathy component. So compensation and decompensation of the cirrhosis is a very delicate balance. Variceal bleed can trigger or can convert a compensated patient into a decompensated patient in a matter of few days or even as early as 24 to 48 hours. Once you understand this, I also want to bring to your notice that what is the site for doing a liver biopsy. As you can see, the patient's right arm is under his head, and we're doing a liver biopsy after infiltrating the site with local anesthesia, and site preparation has been done. So let us assume that this is the mid-axillary line. So in the mid-axillary line, what site would you poke? The answer is 7th or the 8th intercostal space. 7th or the 8th intercostal space is where we do a liver biopsy in the MAL, that is the mid-axillary line, and it should always be ultrasound guided. After doing a liver biopsy, complication that is usually seen is either pain at the site or you could be having shoulder pain. So most of the time that should respond to single painkiller shot, because if it's persisting beyond a particular time and painkiller shot you have given us still there is pain, or it's persisting after, let me say, 16 hours, 24 hours, that means that probably he could have bled internally. And anyway, coagulogram should always be normalized. You must always check coagulogram, PT, APTT, and coagulogram should always be normalized before you do a liver biopsy, because in a cirrhotic liver you're doing a liver biopsy anyway, bleeding chances will be substantially increased. Once the sample has been sent to the laboratory, the histopathologist can use two methods to identify the severity of cirrhosis or fibrosis in the liver. One method is written on the left hand side itself, that is Metavir scale, and the second one is called as Ishak scale. For the parameters of Metavir and Ishak scale in their comparison, you will have to anyway refer to pathology discussion. As far as the grading of this is concerned, from pathology perspective, this would be beyond the scope of this particular discussion, where I will be, as a doctor, more interested in not grading it histopathologically, but to identify compensation versus decompensation. Now, liver biopsy is a invasive method, and we are always looking for non-invasive methods to identify the fibrosis in the liver. So one of the methods that we have now is called as transient elastography. We put a probe on the abdomen of the patient. This will look like an ultrasound, but is different that this will produce vibrations, and it will measure the speed with which the vibrations are reflected of the liver parenchyma. Because you see, if the liver is having, patient is having fatty liver or is having fibrosis in the liver, then the speed with which the vibrations will produce through the liver parenchyma will be different. And this is a computerized algorithm that measures that speed and then analyzes the structural damage to the liver from outside without having to go inside the liver. I said it will measure the velocity of the shear wave, that is the vibration wave which is traveling through the liver parenchyma. The commercial name for this is called as FibroScan. It is good and superior over a routine ultrasound to pick up fatty liver, non-alcoholic fatty liver disease, and even a liver cirrhosis, as I have said. Then we also have a blood test available by the name of FibroSure, which will help you non-invasively to identify fibrosis. The accuracy of this will obviously be lesser than the previous ones. The parameters are bilirubin, gamma GGT, or the gamma GGT that we use in fatty liver. And then you can remember three which are having or can be remembered by a mnemonic HAM. Alphabet H would stand for haptoglobin. That's relatively easy to remember. Haptoglobin is used to bind hemoglobin. Alphabet A would stand for apolipoprotein. These are of various varieties like apolipoprotein A, B. So we're talking about apolipoprotein A. And M would stand for macroglobulin. I have basically in this topic tried to explain to you what methods are we having to identify fibrosis in a patient. First, I've told you about two scores, and the advantage of these scores, why I've told you these two first, is because you can identify compensation versus decompensation and also predict the mortality rates. The mortality rates are the ones which are highlighted with med score. The figures I would like you to remember: at least 20% for med score of 20 and 50% or higher for med score of 30. Then invasive test, which is gold standard liver biopsy. Trying, not being able to, but trying to replace liver biopsy is transient elastography, and then is blood test FibroSure. So one is FibroScans against FibroSure, by which we are able to identify that okay, there is cirrhosis present in a patient. When do you say that the patient is having compensation or decompensation is the main crux of the discussion? In the next slide, I'm deviating slightly from the topic because they have asked a question related to this, but let me explain here and then you will understand the significance of this discussion here. You will notice that whenever liver is damaged, the production of albumin is lesser. Obviously, you know that right from first year. What I want you to know is, or what I want you to answer is that why is it that in all liver diseases globulin is elevated? And while I do some subsequent talking here, the question is still open to you. I mean, why is it that the liver is damaged and globulin is elevated? You can see at the right image, nephrotic syndrome is a condition where albumin in the blood is always less because it is lost in the urine. And in nephrotic syndrome, even globulin is lost in the urine because you see the pores in the kidney are not functioning properly. So albumin, globulin both can be lesser, and patients on nephrotic syndrome can die because of infections because antibodies are lost. The following reports that are shown before you are those of serum electrophoresis. In the exam, they have given these serum electrophoresis reports, and a lot of chaps they did not even analyze these reports. They just answered multiple myeloma because multiple myeloma will always be having a M spike, where in gamma globulin, and here you can't see any spike in the gamma globulin. The last part here is the gamma globulin. You see, first you have albumin, alpha 1, alpha 2, beta globulin, and gamma globulin. That's how it is, no? Albumin, alpha 1 globulin, alpha 2, beta, and then gamma globulin. So multiple myeloma will have a spike in gamma. You can see in the report that is shown on the extreme right hand side, albumin and globulin both are less. So if they give you a report like this, albumin, then okay, alpha 1, alpha 2, beta, and then there's a sudden spike like this, that would definitely be multiple myeloma. Church spire peak, church spire, like the tip of a church, like, you know, I mean, Western countries, they have these churches in Europe with the tip being very pointed. So a church spire appearance, or a M spike as they call it, that is a feature that we see with MM, that is multiple myeloma or plasmacytoma. But in the second diagram that you can see in the middle where I'm marking right now, albumin and globulin both are less, so that is nephrotic syndrome. In liver, guys, albumin is less, globulin is more. Why? Because the catabolism of globulin occurs in the liver. I repeat my statement so that you can understand this better. Catabolism of globulin occurs in the liver, and if liver is damaged, then the catabolism of globulin will become lesser, so gamma globulin values will be elevated. What you've learned here is that if you get a report in which albumin and globulin both are reduced, it is nephrotic syndrome obviously. If albumin is reduced, globulin is elevated, that's a feature that is seen with cirrhosis of the liver. And if albumin is normal and gamma globulin is shooting through the roof, very high values, then in those circumstances, you have to remember that the patient is having multiple myeloma. Let's do this again. Albumin, globulin both are reduced. This would be a presentation of nephrotic, low albumin but elevated globulin. Why? Because the catabolism is not occurring. Therefore, this would be a report of a cirrhosis patient, and gross elevations would be seen with plasmacytoma / multiple myeloma in a patient. Once you remember this detail that globulin is always elevated in patients of cirrhosis, I can proceed subsequently. So cirrhosis patients will always be having globulin. That's the basic objective of discussing with you, and it does not indicate anything related to compensation or decompensation. Now let us see, when will we say that the patient is decompensated or not from the clinical perspective. I'll just show a diagram to you that will make it much more comfortable for you to understand the decompensation stage. Please remember the fact that if a person is having varices, they may not have blood at the moment. But the moment a person starts having ascites and varices which have started to bleed, or even if ascites is present with non-bleeding varices, we will say decompensated. It's a very fine line, but you need to remember this, that if ascites is given in a question, or chronic liver disease is patient having ascites with varices, with or without bleeding, it is a presentation of decompensation. If he bleeds, obviously, you know that is decompensation, and this will trigger hepatic encephalopathy. Why? Because blood is a very good culture medium. Therefore, the concentration of gut bacteria will increase. Where is ammonia produced in the body? Intestinal bacteria. If more ammonia will be produced, that will trigger hepatic encephalopathy in a patient. So that's why it is written coagulopathy triggers hepatic encephalopathy in a patient. Our objective is to intervene before the stage happens, because once he goes into stage 3, stage 4, that is decompensated cirrhosis, then the game is over in a sense that you will have a very tough time managing the patient. I mean, he's having a varicose bleed, he doesn't reach the hospital on time, the person will expire. Or he's having ascites which is causing tense ascites and abdominal compartment syndrome. Again, it's like a fighting a losing battle. So our objective is to identify the disease early. Based on the tests that I've explained to you with respect to cirrhosis, we also need to have a quick look at the causes of cirrhosis in a patient. The most common cause of cirrhosis is alcoholic cirrhosis. That does not mean that portal hypertension will develop in all cases. Portal hypertension takes some time to develop. One of the leading causes of portal hypertension in alcoholic patient is obviously alcoholic cirrhosis, but if it is non-alcoholic, we need to consider other options. Do remember the fact that hepatitis C, and for that matter of fact hepatitis B, can also induce cirrhosis. Hepatitis C incidence is higher. Carriers are more common with B, but cirrhosis is more common with hepatitis C virus. Then you need to remember genetic diseases like Wilson, alpha 1 antitrypsin deficiency, hemochromatosis that have the propensity to cause this manifestation. Then is biliary cirrhosis. In biliary cirrhosis, you need to remember two: primary biliary cirrhosis and primary sclerosing cholangitis, antibody related, autoimmune hepatitis. There are separate lectures on autoimmune hepatitis and PBC and PHC, so you can go through them for remembering the antibodies, though I'll mention them here also. Then an important cause which is not to be missed or not to be forgotten, especially in Indian scenario, is called as NCPF. You see, Harrison will not use this word because he will say the word cryptogenic cirrhosis. But there's a problem that's seen in developing countries mainly, that is called as NCPF, that is non-cirrhotic portal fibrosis. Like this chap, he is not alcoholic, he's never even touched alcohol in his life. His hepatitis B C markers are negative. He never had, casual sexual contact, no IV drug abuse, no genetic disorders, no autoimmune disorders present in the patient, but still there is a development of cirrhosis, and then he ended up with portal hypertension. So what Harrison says is cryptogenic cirrhosis, that is non-cirrhotic portal fibrosis. And then lastly, it could be cardiac cirrhosis. This person is having heart disease like constrictive pericarditis or restrictive cardiomyopathy, and the right side of the heart is predominantly involved. So therefore the back pressure changes will cause hepatomegaly initially, and his liver span would be increased initially, and the ALP would be deranged. These are the causes for development of cirrhosis. The most common one is alcoholic cirrhosis. For practice sake, primary biliary cirrhosis, the antibody is anti-mitochondrial antibody, AMA. Primary sclerosing cholangitis is PNCA. Autoimmune hepatitis can be associated with various antibodies, like one that is worth remembering is liver kidney microsomal antibody. There are many others also, like soluble liver antigen and liver cytosol antibody. So you can read about them in the autoimmune hepatitis section that I have dealt. But then one worth remembering is autoimmune hepatitis with liver kidney microsomal antibody. Cardiac cirrhosis will mostly be patients of constrictive pericarditis or even cor pulmonale patients, because the right ventricle is involved in the patient, and right ventricle compliance is reduced, so there would be congestion in the liver of the patient. So this is the series of causes that would be developing. Initially, when the patient is compensated, you will notice that the features that would be present in the patient will be very classical, like he could be having this spider angioma. Spider angioma will be having a central arteriole which will be filling up these peripheral vessels. The manifestation would be called as spider nevii or spider angioma. In fact, this is what you would have noticed very commonly in your hospitals with alcoholic cirrhosis patients. The hormone responsible for spider nevii is estrogen. This would be a dilated arteriole, don't mix it with caput mucosae, which would be seen on the umbilicus of the patient. Where do you see for spider nevii? Superior vena cava distribution. So you would request this person to take off his shirt, and over the shoulder areas of the patient, front and back, you will be able to see this spider nevii presentation. Do not be under impression that spider nevii are seen only in cirrhosis. They can be found also in patients of rheumatoid arthritis and even pregnancy. So they are not a pathognomonic feature for development of cirrhosis in a patient. Feature number 2, 3, 4 can be seen in the hands of the patient, especially in your hospital. If you're having an alcoholic cirrhosis patient admitted with a varicose bleed, if you have a look at the hands of the patient, though he had a varicose bleed, he might be having the redness, that is palmar erythema. Then can be Dupuytren's contracture. The next manifestation in the hands of this patient can be clubbing. So remember, clubbing can be seen in cirrhosis. It could be alcoholic, it could be biliary cirrhosis in a patient, but 2, 3, 4 are features in the hands of the patient. In male patients, you will always be having testicular atrophy, which will cause this male to have development of gynecomastia. There would be in a male patient decreased body hair, testicular atrophy. Testicular atrophy may or may not be noticed initially, since the patient might be wearing his undergarment, but the gynecomastia component is very easily noticed, especially in alcoholic cirrhosis patients. And the next feature is very specific to alcoholic cirrhosis only, that is parotid gland enlargement. All of these features basically indicate that the patient is still compensated. I mean, why am I saying compensated? Because there is no threat to life at this particular point of time, and based on the MED score reports of the patient or liver biopsy of Ishaq score, Betavir score, I can plan something for this patient. Lots of patients at this particular stage might feel overconfident, they might not seek your advice, though the liver span is gradually reducing in the patient. So you would have a progressive deterioration in these patients, and that is when they go into decompensated cirrhosis with portal hypertension manifestations developing in these patients. Before we talk about what happens in portal hypertension, I would just like to draw a diagram here to explain cardiac cirrhosis component. Let us assume that my patient is having a right-sided heart failure. So this is a crude diagram representing the aorta, the pulmonary artery, and I've now modified the diagrams to show decompensation of the right ventricle of the patient. So the back pressure changes will affect the inferior vena cava also. Therefore, in this patient, the liver will become gradually enlarged, the liver span will be increasing. You see, the surprising thing is I'm teaching you cirrhosis, but I'm saying the liver span is increasing. So in cardiac cirrhosis, initially liver becomes bigger. There's a congestion in the liver parenchyma of the patient, and it becomes relatively bigger in the patient. The highlight of the topic that I'm saying for cardiac cirrhosis would be, and I mean, how do you know it is cardiac cirrhosis? One should obviously be features of right ventricular decompensation in a patient. There should be obviously enlargement of the liver of the patient initially, and a substantial increase of serum alkaline phosphatase in the patient. When you do a biopsy in the patient, or if you do a non-invasive test, that will even immediately start showing up features of cirrhosis. Gradually, initially, first the liver will become enlarged, and gradually the liver will shrink in size in these patients. The finding of these patients in pathology is also referred to as nutmeg liver. So it's just this word that I wanted to highlight. Nutmeg liver is a feature of cardiac cirrhosis. How do you differentiate this from Budd-Chiari syndrome? Well, Budd-Chiari syndrome will not have a right ventricular failure. So no features of RV cardiac involvement in Budd-Chiari is rather that the blood supply to the right side of the heart is significantly reduced. So patients of Budd-Chiari, if they have inferior vena cava obstruction progressively, then they can go into obstructive shock. But otherwise, there is no cardiac involvement per se of right ventricular decompensation occurring in Budd-Chiari syndrome, and Budd-Chiari is usually an acute event. This is a gradual event, so you would be in a position to differentiate between the two. Now, once we understood that, we will talk about what is going to be the complications that will be associated in patients who are suffering from liver cirrhosis. The most common complication that we encounter is portal hypertension. The most common complication that is found in patients with liver cirrhosis is development of portal hypertension. Definition of portal hypertension will be hepatic venous pressure gradient to be in excess of more than 5 mm of mercury. It's obviously a range, but in the current edition of Harrison it is written hepatic venous pressure gradient more than 5 mm of mercury is when portal hypertension will start, and if the gradient is more than 12 mm of mercury, then the patient will have development of variceal bleeding. Why they mentioned two values here is just to signify the fact that in the initial part of the illness, if you identify the disease, you can prevent this deterioration up to 12, and there's a very little mathematical value, only a rise of 7 mm. So how would you as a doctor first identify whether person is or is not having portal hypertension is the objective of the next couple of minutes. Let us assume this to be the portal vein which is feeding the liver. There are two tributaries of it, that is the splenic vein and the superior mesenteric vein. I have now shown fibrosis occurring in the liver. So the blood will have difficulty in going in the liver and the pressure in the portal vein is increasing, and this pressure will be transmitted to the splenic vein and to the mesenteric vein also. Therefore, the spleen of the patient will become congested and will become enlarged in size. So one of the highlight of patients of portal hypertension is development of splenomegaly. It would be congestive splenomegaly which is occurring in the patient, but this is an early sign and a reliable sign for the patient. Subsequently, because of the increased pressure, there would be leakage of fluid from the splenic capillary bed. This would result in or will translate into development of ascites for this patient. The superior mesenteric vein in these patients can contribute to development of portosystemic collaterals in the form of rectal hemorrhoids. Another collateral that could be developing with respect to the esophagus of these patients could be esophageal varices. Initially they are non-bleeding, but then they can rupture anytime and it could be all hell breaking loose in the patient. If I number the sequence here, we first have a splenomegaly, then we have ascites, we start having simultaneously rectal hemorrhoids and esophageal varices gradually developing in these patients. My objective is to identify all of this early. So how would I identify portal hypertension? How would I know that the hepatic venous pressure gradient is more than 5 millimeter of mercury? Then the scan or the test I'll do in the patient will be a Doppler. Whenever you have to check pressure in the blood vessels, you anyway have to do Doppler in the patient. So Doppler ultrasound would diagnose portal hypertension. The leading cause of portal hypertension is obviously alcoholic cirrhosis. That is piece of cake. No big deal for that the leading cause is alcoholic cirrhosis. But if he specifies a question, giving an Indian touch to the question, he describes that person is non-alcoholic. Viral markers are negative. No genetic disease has been identified in the patient. Autoimmunity has been ruled out because autoimmune antibodies are not present in the patient. Still he's having a cirrhosis. No cardiac involvement. Then it would be cryptogenic cirrhosis, that is also referred as NCPF, non-cirrhotic portal fibrosis. So do take a note of what I said. I said in America, alcohol, they drink all the time. Of the colder country, they drink most of the time. So alcoholic cirrhosis is a leading cause. But in India, you have a person who's a teetotaler, who's never touched alcohol in his life, and then I said routine markers are negative, then you have to think in terms of NCPF as a possibility or cryptogenic cirrhosis as well. Moving ahead, when it comes to non-bleeding varices in a patient, the drug of choice should be answered as propranolol. But if he says bleeding varices in a patient, then you need to go in for aggressive management of the patient by using octreotide. Like they've given a scenario that this person has developed vomiting of blood, hematemesis. The most common cause of vomiting of blood is peptic ulcer. How in a MCQ you will know that whether it is a peptic ulcer MCQ or not is with the help of this finding. Hematemesis will be associated with splenomegaly, and you don't have splenomegaly written in peptic ulcer obviously. Initially, since the patient's blood pressure might be unrecordable, so I have to increase it to recordable value of at least 90/60. So what will I do? I will put in a wide bore cannula in the patient and try to get the BP back to normal. I can be using an orange cannula, that would be 14G, or a gray cannula, that is 16G. So wide bore cannula should be deployed in the patient, and if you have to select between orange and gray, first is orange. He mentions that if a doctor has never taken training, if you never put a orange cannula ever in your life, then you should put a gray cannula for fluid resuscitation. And in this patient, you will first start crystalloids in the patient, that is IV fluids, normal saline. In any patient with unrecordable blood pressure, the fluid of choice is always normal saline. Subsequently, you need to ensure massive transfusion protocol for this patient, which would involve giving packed RBCs, fresh vessel plasma, and even platelets if required to these patients. Once you have done fluid resuscitation in the patient, the next thing that would be done would be starting the patient on octreotide. This is a somatostatin analog. It will reduce the pressure in the splenic circulation, so the bleed will ease off. Now, You will be performing a upper GI endoscopy in the patient, and you will inject a sclerosing agent into the veins so that they do not bleed ever again. That is sclerotherapy. So the steps to be followed are: first, fluid resuscitation, massive transfusion protocol. Ensure that the BP does not come back to normal 120 by 80. We need permissive hypotension. I don't want the BP to suddenly spike to normal values. That will further increase the bleeding of the patient. So I need to ensure only 90 by 60. That will control the bleed. And then subsequently, I need to go in for endoscopy with sclerotherapy, which should be answered as the treatment of choice for this condition, whereas the drug of choice for this patient would be answered as intravenous octreotide. And for non-bleeding varices, as I explained to you, it is propranolol that would be used. For the topic of portal hypertension, they would also like to sometimes trouble you by writing down pre-hepatic causes or hepatic causes or post-hepatic causes. So we have to be ready with this table also. So I'm very sure you have read this multiple times in the book. It's a quick overview, so let's just go through it. Prehepatic can be either portal vein thrombosis, that could be due to infection, portal vein or splenic vein thrombosis, or they could be even hematological disorders, like I can say polycythemia vera, where viscosity of the blood is more, multiple myeloma, where viscosity of blood is more. So it's not only infection, it could be hyperviscosity, which can contribute to portal vein and splenic vein thrombosis in a patient, resulting in problem occurring before the liver, so we call it a prehepatic cause. Then is a rare disorder, but it is given in Harrison, so mentioning before you, that is Bunty, BANTI, Bunty syndrome. This will be having massive splenomegaly. In India, you read about massive splenomegaly with Kala Azar. In pediatrics, you read massive splenomegaly with Gaucher's disease. But I'm telling you, massive splenomegaly in chronic paraleukemia and Bunty's disease is also to be kept in mind. Let's fill up the post-hepatic causes easily. Budd-Chiari syndrome, that's a separate lecture that I have taken, so you can go through that. There could be webs in the inferior vena cava. They will cause obstruction and they can be triggers for development of Budd-Chiari syndrome in a patient. And then could be cardiac causes. Cardiac causes would mean restrictive cardiomyopathy, constrictive pericarditis. They will all limit the filling of blood in the right side of the heart. So congestion will occur in the liver of the patient, and ultimately if there's congestion in the liver, there would be congestion in the portal vein. So portal hypertension. For the hepatic causes, they have subdivided this into pre-sinusoidal, sinusoidal, and post-sinusoidal. When I say sinusoidal, that is cirrhosis of the various etiologies that I have mentioned. So I'll just jot that down. Sinusoidal cause is cirrhosis of the various etiologies. For the pre-sinusoidal variety, you need to remember regarding a worm infestation, that is schistosomiasis. Schistosomiasis can be either in the vesical plexus or in the hepatic circuit. The post-sinusoidal cause which is to be remembered is very peculiar and is called as VOD, veno-occlusive disease. Before I mention causes for it, just let me mention the word post-sinusoidal. So we have subdivided the hepatic cause into further three: pre-sinusoidal and post-sinusoidal. For veno-occlusive disease, the two reasons, why would it develop? That's the usual carry from most doctors. One is radiation, like this person maybe was being planned bone marrow transplantation for some disorder. So when you give radiation, pan radiation for priming of the patient for bone marrow transplantation, there could be a veno-occlusive disease developing. And then I want to tell you herbal tea. Now, not the routine herbal tea of a good brand that you drink, so don't think that herbal tea will cause this. But the poor quality herbal tea or what is so-called Ayurvedic medicines over the internet, they can contribute to a manifestation like this. And while I'm saying this, I would like to tell you that Chinese herbal medicines, which are increasingly being used by your patients apart from Ayurveda, they contain a product called as aristocolic acid, and aristocolic acid intake can contribute to renal failure. So those so-called Chinese herbs can actually cause damage to the kidney. And today I told you these poor quality herbal tea is available without any branding. They might be having constituents that can cause a veno-occlusive disease, and that is a post-sinusoidal cause. Now, once portal hypertension has occurred in a patient, then the next thing that will happen would be that due to increase in the pressure in the capillary bed of the spleen, there would be transudation of fluid, so there would be ascites developing in a patient. As my patient of cirrhosis will start developing ascites, he has now gone into decompensated stage. So if you are having a cirrhosis patient who is going into ascites, that means that the deterioration part has already started. How much ml of fluid is present in peritoneal cavity of a normal man? The answer is 0 ml. There is no fluid present in peritoneal cavity of a normal male patient. How much fluid is present in peritoneal cavity of a female? Answer is again 0 ml. There is no fluid in the peritoneal cavity of a male or a female. Yeah, in a female mid-cycle, when ovulation will occur, then the amount of fluid could be something in the range of 10 ml. So I'm talking about Mittelschmerz, where the mid-cycle, when the ovulation will occur, they could be about 10 ml of fluid in the peritoneal cavity. Otherwise, we don't have any fluid in the peritoneal cavity. In pleural space, the amount of fluid which is present is in the range of about 5 to 15 ml. In the pericardial space, the amount of fluid which is present is approximately 20 to 50 ml. So more than this would be pleural effusion and pericardial effusion respectively, but there is no fluid in the peritoneal cavity of a normal male or a female. If the amount of fluid in the peritoneal cavity increases to more than 100 ml, that is when we get clinically puddle sign. That is itself a question. Puddle sign will become positive at more than 100 to 120 ml. Ultrasound can detect even lesser than that, even 50 ml can be picked up, but 100 ml is where you would be having a puddle sign. And when the amount of fluid will increase to something in the range of 500 ml, that is when you would be having shifting dullness developing in a patient. You will have to do percussion in the patient, then turn the patient to the contralateral side. So all the fluid will gravitate to the contralateral side. So the note will change. The dull note that was coming, that will change to tympanic note, because now there is bubble, there is no fluid, because the fluid has moved to the contralateral side. As the amount of fluid will increase, you might even start having a finding of fluid thrill developing in a patient. The ascites patient of mine is now beginning to deteriorate and is getting converted into massive ascites. When do I say massive ascites? There is no fluid criteria that okay, more than this much will be called as massive ascites, because it depends on I would say the height and the build of a person. Like suppose there's 1.5 liter of fluid. If it's a short height person, 4 feet 8 inches, even 1.5 liter will be called as massive ascites. And if it's a very tall person, that even 3 liters might not cause very substantial abdominal distension. So massive ascites is based on presence of one fluid thrill developing in a patient. There will be breathing problems or respiratory difficulty that will be experienced by the patient progressively, because the movement of the diaphragm can be affected, especially on lying down. The superficial veins of the abdomen will become more prominent, more visible. Caput medusae at this point of time might be well developed. In fact, one of the indicators that portal hypertension and ascites both have now progressed in the patient is development of caput medusae. The superficial veins will be very prominent on the abdominal wall and caput medusae would be visible. Do remember the fact that in caput medusae the flow of blood is not towards the umbilicus, the flow of blood is away from the umbilicus, away from the umbilicus. The same patient of massive ascites, if you do not evaluate properly, might progress into tense ascites. His clinical features will now worsen. His respiratory difficulty will increase. The superficial veins will become tortuous. His umbilicus will all be pouting outwards. So the difference between massive and tense is only in relative terms, that the superficial veins are so dilated and tortuous that it will look as if you can put in a cannula. So for patients of tense ascites, why he's sitting on a time bomb is because he can deteriorate into abdominal compartment syndrome. When do you say abdominal compartment syndrome? Is when the pressure in the peritoneal cavity will turn to be more than 25 millimeter of mercury. It's going to cause compression of the superior mesenteric vein. It will cause compression of the inferior mesenteric vein, and the compression of the SMV and the IMV will contribute to development of gangrene of the intestine. Now this is a very unfortunate complication that will develop in a patient. The compression will contribute to abdominal compartment syndrome and a development of gangrene. And my role as a doctor is not to let this happen. So what I'm gonna do in this patient, I will prevent this manifestation from occurring by here intervening and do a abdominal paracentesis in a person. In a patient of massive ascites, if you have to prevent deterioration into tense ascites and abdominal compartment, you have to go in for a paracentesis in this patient at this particular point of time. And if you remove the fluid from the peritoneal cavity, then the chances of this is minimized. Listen to my next thing very carefully. The good news is that I have done an abdominal paracentesis in a patient of massive ascites in my hospital. This will prevent deterioration of the patient, but at the same time, because large amount of fluid has been removed from the peritoneal cavity of the patient, dehydration of the patient will occur. Since there is a dehydration, the concentration of ammonia in the body of this person will rise, and this can trigger asterixis in this person. Remember, this was a cirrhotic patient. He was an alcoholic cirrhosis patient. He came with massive ascites. You did a ascitic tab, and due to dehydration, asterixis is triggered. I was trying to do benefit for the patient. The large volume paracentesis that I have done in the patient has unfortunately resulted in development of asterixis in the patient. So the question then arises, was I right in my decision of trying to remove the fluid in a single sitting? Should I have not waited and removed fluid in installments? Please appreciate that first common sense tells us that we should not be allowing this to happen in our patients. We should not have taken out the fluid in a single sitting. However, if I told the patient that I will be taking out little bit of fluid every time, what's going to happen is that if you puncture the peritoneal cavity again and again, the chances of infection will increase, the pain and disability of the patient will increase. So I have to take a decision at this point of time that should I go for large volume paracentesis or should I, remove in smaller installments. What I've decided now is that I will remove in single go, but how is it possible that I can remove in single go without causing asterixis? I mean, I don't want all this. So, to prevent this from happening, before we start the procedure in any patient of massive ascites, we give salt-free albumin. Now see what salt-free albumin will do. When you administer albumin before you start the procedure, it will increase the oncotic pressure. Obviously, albumin increases oncotic pressure. This will cause mobilization of fluid. Now you need to listen to my words very carefully. It will cause mobilization of fluid from the peritoneal cavity. Whatever fluid is wasted in the peritoneal cavity of this alcoholic cirrhosis patient, some of this fluid or most of this fluid, due to increase on oncotic pressure, will start moving back into the intravascular compartment. Read this statement once again. I said, when you give intravenous albumin to the patient, it causes mobilization of fluid from peritoneal cavity back into the intravascular compartment. The moment that happens, the chances of dehydration in this patient, which I was talking about superiorly, have dramatically gone down. If you missed it, I'm going to repeat this again. I said if you give salt-free albumin before the procedure of massive paracentesis, because the fluid of the peritoneal cavity will go back into the blood vessels, the chances of dehydration is minimized, and I can reduce the chances of development of asterixis in a patient. So in all patients of massive ascites, first we give salt-free albumin and then we go in for a LVP. LVP does not mean a low volume, it basically means a large volume paracentesis being done in the patient. This is the treatment algorithm that is recommended for massive ascites in a patient. Let's just revise the aspects that I have said here before you. I have today told you that if a person is having ascites, it means that already the cirrhosis part has decompensated. What will you do in ascites? You will tell the patient to take salt-restricted diet. Why? Because ascites is a condition of secondary hyperaldosteronism. Already aldosterone is so high, so water is coming back, salt is coming back, so person is anyway deteriorating. So if I give salt-restricted diet, I will be able to minimize the discomfort of the patient, and then I will also give a drug to neutralize the elevated aldosterone. The drug that I will give to neutralize the elevated aldosterone is spironolactone. So treatment for ascites is salt-restricted diet and spironolactone, but most patients go on a cheat diet. Why cheat diet? Because I would say like this, that food without salt looks horrible or tastes horrible. If you ever had food without salt, it's really horrible. So most patients would say, yes, I'm not taking salt, but they would still be cheating by taking salt in the diet, maybe even higher than what you've allowed. on minimal grounds. So massive ascites can develop in a patient, and if that will happen, you will have to give to the patient first a salt-free albumin along with LVP, that is large volume paracentesis. I repeat my words. In MCQ, it will be written low volume paracentesis in one of the choices also, but we don't go for large volume, we go for low volume paracentesis. In some cases, there can be refractory ascites also. What I mean by refractory is medically refractory, because if you take out the fluid, obviously, you will resolve the problem. But I'm talking about refractory ascites in a patient. So when do we see refractory? You are giving drugs to the patient, how much? So drugs that are recommended if person is having ascites and it's not responding to medication is spironolactone. The maximum dose of spironolactone that you can give to the patient is up to 600 milligram per day. You can simultaneously use furosemide. Now traditionally we use furosemide in flash pulmonary edema, acute deep compensated heart failure, but today I'm teaching you furosemide even for patients of refractory ascites, and the max dose that is possible is about 160 milligram. I'm talking about oral treatments here. So look at the amount of medication my patient is taking. 600 milligrams of spironolactone. Normally we give like 25, 50, max 100. Here you are giving 600 milligrams spironolactone, 160 milligram of furosemide, and still the ascites is present in the patient. So the complete data is ascites present in a patient in spite of aggressive pharmacological treatment for the patient. Spironolactone furosemide is being used, then you will say person is having refractory ascites. The last term that I can say is recurrent ascites. I'll not write it because if a person, that's logical, that's why I'm not writing it. If a person is having recurrent ascites, you see lots of time you will notice that in government hospitals, alcoholic cirrhosis patients, they make a habit of this. Every 2 months they come, or every 1.5 months they come. You put in a needle, you remove the fluid, again he'll go back, again come back, again you'll do the same procedure. And well, this is not the ideal way, in a sense that ideally we should have done a transplantation long back. Now, since we did not agree for transplantation, we could have tried a shunt surgery in the patient. So my message here is that if a person is having recurrent ascites, we need to get a surgical consult for the patient for the feasibility of a shunt surgery in the patient, like a TIPS procedure. Though a disadvantage of TIPS procedure is hepatic encephalopathy. So current studies have said that wherever feasible, they have said wherever feasible, TIPS can be done for persons having recurrent massive ascites. The word is wherever feasible, and the side effect of hepatic encephalopathy has to be kept in mind. But otherwise, for recurrent ascites, in government hospitals, most of the time what is happening is that every time he will have a problem, breathing difficulty, he'll come to you, you will do a tap, send him back home. What is the site for tap? We can just have a look at this site for ascitic tap. We can take this to be anterior superior iliac spine. This is umbilicus. This is rectus abdominis muscle, midline. So when you do a tap in the patient, it has to be going a little medial to the anterior superior iliac spine, approximately 3 centimeter. That's little more than an inch, and then you go 3 centimeter superiorly. So it would be almost in the flanks that you are putting a needle, and you would be taking out the fluid in the peritoneal cavity of the patient. I am now in this diagram representing a blood vessel which would be running like this and can be traumatized. The name of this blood vessel has been asked in an applied anatomy question, that is inferior epigastric artery. So one, I want you to remember the site for ascitic tap is slightly in the flanks or almost on the flanks, and that would be 3 centimeter medial to the anterior superior iliac spine. The red marking is ASIS, and then 3 centimeter going superiorly from that. Inferior epigastric artery can be traumatized during the process or during the procedure, so you have to be a little careful. And if you treat ascites aggressively, you are on safe grounds. Why? Because I have a patient of massive ascites in my hospital who has been admitted since 5 a.m. in the morning, and suppose I'm saying it is like 12 o'clock in the night. Like, this person was admitted 5 o'clock in the morning and massive ascites patient, and it's 12 o'clock in the night. You were busy attending to MI, head injury, pulmonary embolism, pneumonia, CLWs, RTAs coming in, that you did not get time to handle this patient of massive ascites, and this person can deteriorate while in the hospital premises. Why? Let us assume this is the representation of the loops of the bubble, and inside the loops of the bubble would be multiple bacteria including E. coli. Now, E. coli is a very greedy bacteria. What I'll say next might surprise you, but you need to understand this, that these bacteria can migrate out of the edematous bubble wall to the lymph nodes, and from the lymph nodes can go into the peritoneal space. I'm saying a very surprising event occurring here in a patient of massive ascites, which is transmigration of bacteria. You can see there is transmigration of bacteria which is occurring out of the bowel wall. They're going to the lymph nodes, from lymph nodes to the lymphatic fluid. There is transmigration of bacteria out of the edematous bowel wall. That's the technical term, edematous bowel wall. And we are having bacteria which are going into the peritoneal cavity of the patient. The bacteria, if they're present in the peritoneal cavity, you are having pus. You are having neutrophils attacking these bacteria, so peritonitis is occurring. So, spontaneous bacterial peritonitis is the aspect that I'm speaking before you here. SBP or spontaneous bacterial peritonitis is a complication that is noticed in patients of cirrhosis who are having a massive ascites which has not been managed properly, and there's a possibility that this person might then go into sepsis. He might go into septic shock. He might go into multi-organ failure. And once he will go into septic shock, the perfusion of the kidney will also reduce. This is going to contribute to renal shutdown in the patient. That would be called as hepatorenal syndrome. Or the perfusion of the lungs of the patient will also be affected. That would be called as hepatopulmonary syndrome. For hepatorenal syndrome, I have shot a separate lecture, so I would suggest you to go through that. But at the moment, I'm trying to tell you that once the deterioration of these patients will begin, it will be a progressively downhill course for these patients, and therefore the chances of death in the patients would be increased. I'll just summarize what I said. I said once the decompensation will occur, portal hypertension will be the first event. And how do you know it is portal hypertension? Varices. As long as varices are not bleeding, cool. But once they start bleeding, all hell breaks loose for the patient. So they can be hematemesis that can cause shock. The examination finding a splenomegaly will always be there. Now these patients will start having ascites that can get converted into massive ascites, tense ascites, abdominal compartment syndrome. And even if that does not happen, ascites can be having a complication developing where the fluid can get infected, that is spontaneous bacterial peritonitis. This can compromise the blood supply to the kidney because he will go into septic shock. So HRS will develop, hepatorenal syndrome, which is of two varieties. Type 1 will develop very fast over 2 weeks and 2 will develop gradually. Type 2 is more common with refractory ascites, and type 1 is rather fast deterioration in 2 weeks period, and creatinine will start rising. Just to see if you understood me or not, if they ask you what is the treatment for hepatorenal syndrome, your answer would be liver transplantation. Why? Because liver is at fault. It's causing a renal failure. Problem is not in the kidney. Kidney biopsy is normal in hepatorenal syndrome. In fact, I can just jot down the question here. Kidney biopsy will not show any findings here. Kidney biopsy, though we don't do that, but this is academic class, so that's why kidney biopsy is normal in hepatorenal syndrome. What is the type of renal failure seen in hepatorenal syndrome? It is the pre-renal variety. So when you will go through the acute kidney injury section, you will notice right in the beginning I have mentioned that acute kidney injury, AKI, is the pre-renal variety. And then HRS in a patient, the drug of choice for management of this condition is midodrine. And the treatment of choice for hepatorenal syndrome is OLT, that is orthoptic liver transplantation. So person is deteriorating. Similarly, the lungs will also be affected, so there will be hepatopulmonary syndrome developing in a patient. One of the highlights of hepatopulmonary syndrome is a development of breathlessness in sitting position, that is platypnea. Or he will use a term orthodeoxia. These are very peculiar terminologies that I want you to remember, and though they are discussed again in the hepatorenal section, here I'm just mentioning the terms here that normally you read about platypnea with atrial myxoma. But I want you to remember this with also hepatopulmonary syndrome. And because the liver is damaged, coagulopathy will soon ensue, so bleeding manifestations will occur. And if he will bleed internally, then I told you that internal bleeding would mean that blood is a very good culture medium. So the concentration of ammonia will rise, and that will result in encephalopathy. So you can see that everything is interrelated. One after the other complications are occurring. All of this is progressive deterioration in a patient. If all these aspects are occurring, we are talking about decompensated cirrhosis. This Nothing of this would have occurred had the patient listened to you, and he would have got a liver transplantation earlier on the basis of the MELD score, on the basis of the Child-Pugh score. Then all of these complications could have been prevented in the patient. Otherwise, these all indicate a deterioration of a patient, that is decompensated cirrhosis in a patient. To finish this topic, lastly, I would like to speak a few more words about the topic of ascites, which I've explained to you, because there have been some miscellaneous questions on what is called as SAG, that is serum albumin ascites gradient. Because it's a mathematical concept, I did not broach it at the initial part, because then I wanted you to have a continuity of thought of what is the complications that are seen in these patients. Now we will talk about serum albumin ascites gradient. It is a simple gradient, which means that you will subtract from serum albumin the albumin in the ascitic fluid. There can be two possibilities. Either the value will be more than 1.1 gram per deciliter, or it will be lesser. So we will first look at the arrow, which is more. Why is it more? Because there is an increased pressure in the hepatic sinusoids. I mean, when you read this more than 1.1, it means that there is an enhanced pressure. The thought process of yours should be more means there is increased pressure in the hepatic sinusoids. A condition causing increased pressure in hepatic sinusoids is the topic we were discussing, complication of cirrhosis, the most common one, that is portal hypertension. So in all patients who are having increased pressure, that is portal hypertension, this value will be more than 1.1. Now what he has done is he has subdivided the discussion into two by the following aspects. He has said that you can also check for the protein in the ascitic fluid. The ascitic fluid protein can be less than 2.5, or the ascitic fluid protein can be more than 2.5. So let's look at what does he mean by this, that the ascitic fluid protein is more than 2.5 or less than 2.5. If you read less than 2.5, this means the fact that the synthesis of albumin is compromised. And condition in which the synthesis of albumin is compromised, because protein is mainly albumin that we are talking about, so the albumin component here is significantly reduced, the synthesis is reduced. This means the disease that we are talking about is cirrhosis of the liver. All the varieties of cirrhosis that we are discussing, which will ultimately result in portal hypertension, they all have gradient more than 1.5, 1.1, but the ascitic fluid protein is lesser because, as I said, I mean, it's not getting synthesized. On the other hand, if you look at the cardiac causes, like a person is having heart failure. In heart failure, again, the pressure is more in the liver, because the heart pressure will be transmitted to the liver, but the synthesis of ascitic protein or albumin in the ascitic protein will remain normal, because heart failure does not interfere with the synthesis. So conditions like restrictive cardiomyopathy, constrictive pericarditis, I mean, the cardiac causes of ascites, they would fit into the pressure being more than pressure being higher, so the gradient is more than 1.1, but the ascitic fluid protein in these patients is in the normal range. Let's now look at conditions where the value would be lesser. For this, you can use a mnemonic, that is BNPT. So leave a little space around P, because I will use alphabet P 2 times. So when it comes to alphabet B, that would be a little peculiar name, but still to be remembered, bilic. Alphabet N would stand for nephrotic syndrome. Why is it less in nephrotic syndrome? Because in nephrotic, serum albumin is also less and the ascitic fluid protein is also less. So because both parameters in this formula become reduced, so therefore the value becomes less than 1.5. Alphabet P would once stand for peritoneal carcinomatosis. Cancers that cause peritoneal carcinomatosis would be like ovarian cancer or stomach cancer, colon cancer. They can metastasize to the peritoneal cavity of the patient. The alphabet P is to be remembered for second time for pancreatitis, and T would stand for tuberculosis. So if you remember the mnemonic BNPT, you will be in a better position to solve this question of, just write the mnemonic here, BNPT. You would be in a better position to solve this question of SAG less than 1.1 in a patient. Do try to practice this table so that the orientation becomes relatively better. though this looks like making you cram the data, but then I have tried to knock some sense into it. So I'll just mention the logic once again before we end up on this topic. That is, if the value is more than 1.1, that's because of pressure pushing from behind, so value is more. And then ascitic fluid protein is lesser. Why? Because synthesis is not there. So cirrhosis, portal hypertension, they are on the extreme left hand side of the table. If it is going to be cardiac causes for cirrhosis and then a portal hypertension, then pressure is obviously more, but the ascitic fluid protein synthesis is normal in the patient, and BNPT for the right hand side. So that will make, I hope, make more sense into the table that you have been studying from a very long time, I would say, and you are aware of all this, I would say. So nothing great, but yeah, I mean, some people I have found, they tend to mess up with the mathematics component of it. So I have spoken about this domain as well. So these are the aspects for remembering cirrhosis and its manifestations in a patient. Thank you for your patience, for listening me out. Keep the faith, keep working, and you would definitely, I'm not gonna say things like you will rock the paper and stuff like that. I will say that you will come out with decent ranks. Thank you so much for listening.